So what we tried to do when we put together this presentation, because there was a group of us, was really think about what does a trip to accreditation look like? What information would you need? And we know that some people have no knowledge about what's been going on or what's happening. Some people have more knowledge. And so we tried to find a happy medium. So you may be hearing things that you already know. But we wanted to make sure that we had everyone on the same level, because through the Gaining Ground Coalition, the work that we're going to do over the next year and a half kind of builds off of where we start today. And so we felt like it was really necessary to make sure that we were all on that same playing level as we proceed through the next year and a half for this funding. So we wanted to talk to you a little bit about history of standards and accreditation, both at the Iowa level and the national level. And so here is your history. Dr. Eckhoff wrote this part of the presentation. If you don't know him, he is a master historian, so I can only hope that I do it justice as we go through this. But in 1867 was the first time in Iowa law that local boards of health kind of came into being. It was the townships or the city councils of the county that formed the local board of health. It wasn't until 1880 that we had the state board of health. And then 1922 is when we decided maybe there should be county health departments here in the state of Iowa. And in 1924 came the state health department. So we're not even really 100 years old yet, which is kind of amazing. So next slide. So the Middle Ages. In 1964, the governor pulls together a public health advisory committee. And they decided that we needed more formalization of public health at both the local and state level. They started locally in 1967. It took them a couple of years to get the law passed, the Local Board of Health Act. And basically it put in place that we were going to have local boards of health. It talked about who should be on the local board of health. But it didn't, and it gave them responsibilities, but not really the depth of information that they needed to carry out those responsibilities, if that makes any sense. It was kind of an overview. This is what the local board of health would do. It wasn't until the 1970s and a little bit later that we were able to give better guidelines to local boards of health about what their requirements should be, roles and responsibilities, and we're able to flesh out a little bit more about what public health should look like. So we had that in place when in 1988, the Institute of Medicine wrote kind of the first outside look at public health in quite a long time. The Institute of Medicine is a nonprofit. It's not funded by government, and they bring in experts to write these reports. And what they found, this quote is pulled directly from there: "No citizen should be without access to the benefits of public health protection through a local public health delivery system." That was really their feeling as they did the report. But they also found that 2/3 of the United States population was not effectively being served by public health. They felt like public health was confusing, that public health didn't really understand what it was doing. We didn't have a great way of defining what public health was. And so they decided at that time that we needed to add, again, more formal structure to what public health looks like. And that's when they came up with the 3 core functions of public health: assessment, policy development, and assurance. So assessment being kind of that bedrock of everything that we do. If we don't know what's going on, then we have a really hard time targeting our resources and figuring out what to do. Policy development, kind of based on that assessment. What rules, ordinances, laws do you need in place? What policies and procedures do you need in place in order to meet the needs of your community? And then finally, assurance, making sure that the policy that you developed to address what you found in the assessment really worked. So that's really brief core functions. Questions about that? Okay, so we had those core functions, and as nice as I just made them sound, people interpreted them differently, broadly. And so again, we decided that we needed to add more formal structure to what public health should look like. And so in 1994, they pulled together the core functions of Public Health Steering Committee. And these were folks from CDC, national public health associations, local public health departments, and they decided that public health really needed a mission and a vision, and this is where the 10 essential services came from. So the 10 essential services were meant to better describe kind of those 3 core functions. It just added a little more explanation to it. Here are the 10 essential services. The 10 essential services kind of fall under the core functions. So you see assessment, policy development, assurance around the outside of the circle. So under assessment, monitor health, diagnose and investigate. Under policy development, we need to inform, educate, and empower people. A lot of our work, you guys know, we do in community partnership. It's very important to make sure that we have people at the table to help us develop the best policy, more partners to do that work. Developing those policies to make things more formal, enforcing laws, linking to and providing personal health services, assuring a competent workforce, and evaluating what we do. At the middle is research, which is the 10th essential service. And basically what the core functions steering committee decided was that public health was going to change. And we all know that it does. New things happen, there's new technology, there's different diseases, new vaccines, and so we're going to constantly be needing to do research. And so research was kind of made a part of the 10 essential services of public health to really help us understand kind of that ever-expanding agenda of public health. You might also recognize the 10 essential services are the roles and responsibilities of the local Board of Health in Administrative Code 64177. So, I mean, it has been adopted pretty widely, the 10 essential services, by the state of Iowa and nationally as well. So I thought this was funny, Dr. Eckhoff. Modernization times instead of just modern times. You guys don't get it. Okay, there we got it. Okay, so Iowa started working on public health standards and looking at this in 2003 and 2004. Dr. Hansen was the health department director at the time. She sent the executive team out to do regional meetings, which were more like listening sessions where people just kind of complained about what was going on with public health and tried to provide some guidance to her as a new health department director about what they would like to see and how public health could move forward. And when she got back from those meetings, she basically put a group of about 12 people into a room. They were state and local public health professionals, and she said, okay, so here are the things, let's figure out what we should do. And it took them about a year to come up with a recommendation, and they were brutal meetings, it sounds like. I'm very grateful maybe to not have been a part of that process. But they worked, and they decided that we really needed standards for public health in Iowa, that we needed everyone to understand what to expect from public health in Iowa. There were other states who had developed standards. It was working really well for them. And so we decided that if we had standards in place, then that would kind of provide a common terminology for public health. It would be a good mechanism for educating new local Board of Health members, new local public health administrators, because even then we were experiencing a high turnover of local public health administrators. So that's been going on for a while. So they decided that we really needed to answer the question, what should every Iowan reasonably expect from state and local public health? And also we needed to modernize an integrated, sustainable public health system that ensures a basic standard of delivery to all Iowans. And we recognized as we started this work that there are a lot of unique situations in local public health departments across Iowa. And there's this saying that if you've seen one local health department, you've seen one local health department. I think that's true to an extent, but we kind of saw that not always as a good thing, right? Because we should be able to have people move from county to county and have access to the same level of services and have an understanding about what's going to be available to them. So we came up with the public health standards. So we developed work groups to develop the Iowa public health standards. There were around 250 people involved with developing the Iowa public health standards. I think a few of you were involved in developing the standards. So we developed them in 2 categories, the first being infrastructure. So part of public health is just making sure that we have kind of our ducks in a row to be able to provide public health services. So things around administration like contracts and budgets and audits, all of those things are important. Governance looked at the role of the local board of health and what the local board of health should be responsible for and how they should communicate with the department. Communication and IT was kind of a pairing of having the information technology available to do your work, making sure that you also were communicating through a PIO if at all possible, communicating during emergency situations, recognizing special populations that you needed to communicate to. So that was that section. Workforce looked at requirements for specific positions in local public health and state public health, specifically the local public health administrator, environmental health administrator, and the public health manager. It also looked at the need for continuing education for public health departments and employees. Community assessment and planning got to the China HIP process, the community health needs assessment, health improvement planning process. And then evaluation, which was making sure we were doing what we needed to do, performance measures, quality improvement, all of those things were part of evaluation. And then we had the services that we had standards around. So prevent epidemics and the spread of disease, environmental hazards, prevent injuries, promote healthy behaviors, prepare for, respond to, and recover from public health emergencies. And I don't know why prevent epidemics is on there twice, so I apologize for that. But those were the components of the Iowa Public Health Standards. We tried to stay away from specific programs like maternal child health or some of those kinds of things because some of that got into the unique aspects of public health or the county that you were in. We just really, again, tried to stick at what should be the basic requirement that every Iowan should have. In 2007, those standards were approved, and we had them, and we kind of went, huh, we think these are great, but now what do we do with them? So in 2008, we put together an implementation plan for how we should proceed, and that implementation plan included an Iowa voluntary accreditation process. We put it into law, and so the Public Health Modernization Act passed in 2009. The Public Health Modernization Act put in place the Public Health Advisory Council, the Public Health Evaluation Committee, and the Public Health Fund. So the Public Health Advisory Council is kind of the body in charge of looking at the governmental public health system, trying to be aware of what's happening, what's changing, and make recommendations to the State Board of Health about maybe how we should move or what that could look like. The Evaluation Committee was charged with evaluating kind of the health of the governmental public health system. What does it look like? What services do we provide? How unique are we? Some of those kinds of things. And then the Public Health Fund was put in place to help local public health departments and the state public health department ready themselves to meet standards. 70% of the fund has to go out to local public health departments. 30% can be at the state health department. We've spent about 8% of that fund over those years at the state health department. The majority has gone out to local public health departments for quality improvement projects, pilots, and some of those kinds of things. So in 2010, the Advisory Council really did a lot of work around the accreditation process, what it should look like. In 2011,